Hello, my name is Crystal Vasquez, and my presentation will be based on standardizing preoperative cognitive screening in older adults. So why cognitive screening matters? 10 to 40% of older adults experience postoperative delirium or cognitive decline. This is associated with increased morbidity, length of stay, and mortality. Preoperative cognitive status is rarely assessed or documented. So as an anesthesia provider, I've seen firsthand how devastating postoperative delirium can affect the elderly population. It's heartbreaking to watch someone wake up confused, frightened, anxious, and unable to recognize their loved ones. And in all honesty, they're in a very vulnerable state in their life. I was very close to my grandparents, so I hold the elderly population very dear to my heart. And the truth is, much of this is preventable. Yet we rarely ask about or document cognitive function before surgery. We do the basic clicking of yes or no for a GCS, but that's pretty much it. It's time to shift our mindset. Cognitive screening should be used not just be used as routine checking vitals. This is about preserving dignity, improving safety, and delivering the quality care of older adult patients. Clinical evidence for screening. I'm very passionate about this topic because we now have the tools and the data to make a real difference. Screening tools like the MiniCog, the MOCA, and 4AT are quick and validated, non-invasive, and incredibly informative. These tools help us guide our anesthetic plan, consent, and post-op care, and actually can reduce delirium incidence by up to 40%. A little bit more about the MiniCog. It's used to screen for dementia quickly during routine annual exams or other medical visits. It only takes 3 minutes, so it's a quick 3-minute way to assess for early signs of dementia. The initial phase is a 3-word recall where you will tell the patient 3 words. They're going to be unrelated, and then you're going to make them repeat them back to you to make sure that they understood those words clearly. You'll let them know that after the following task, they're going to go ahead and repeat those words to you. And then you're going to go based off of a scoring system. So the second phase is where you'll draw a clock. It's called the clock drawing test. You give the patient a blank sheet of paper and ask them to draw a clock, put in all the numbers, and set the hands to 10 past 11 or 11:10. This tests executive function and visual-spatial skills. So the 3-word recall you'll ask them again after this clock drawing test. You'll tell them to tell you the 3 words that you had initially told them. So the way the scoring system works is the recall score, you'll have 1 point for each word remembered, so you have a total of 3 points. You'll have the clock drawing, which is considered normal or abnormal, not scored numerically. 0 recall words is indicative of a high likelihood of dementia. 1 to 2 recalled words plus abnormal clock is possible dementia. 1 to 2 recalled words plus normal clock less likely of dementia. And 3 recalled words is a low likelihood of dementia. These assessments give us a chance to tailor our anesthetic plan, as I said, and alert our teams early to take action early. Just imagine how many complications we could avoid by identifying vulnerable patients before surgery begins. The evidence is clear. Preoperative cognitive screening works. It's just time we implement it widely. Departmental policy proposal. This isn't about adding another burden to our workflow. It's about showcasing the efficiency of our process to make it safer and smarter. The MiniCog only takes 3 minutes to complete. That's a small investment for a huge gain in safety. By building it into our EMR and training our teams, we can make this a new standard. I believe every patient age 65 and up deserves this level of care, and we have the power to make it happen. Leading change through engagement. As we know, leading change is never easy, but it is necessary in order to grow. I propose we apply Cotter's model, build urgency, form a coalition, and empower our staff. We must lead this initiative across anesthesia, surgery, and nursing to create a unified effort. With champions in place and outcome tracking, we can measure our impact and adjust along the way. This is more than a policy, it's a movement toward a safer, patient-centered care. So the time to act is now. We are at a turning point. We can either maintain the status quo or we can make a standard for our patients. Standardizing cognitive screening is an easy, evidence-based, and powerful intervention. Let's not wait until the next adverse outcome to act. Let's be proactive, compassionate, and bold in our leadership. Our older adult populations are counting on us, and I know we can rise to the occasion. Attached are my references. Please let me know if you have any questions. Thank you.